Going.
Okay.
I think we're on. Hey, Nicole. Hi, guys. No one's on TikTok yet, but I'm sure they will be. Parham, how are you, man?
I'm doing good, man. It's Monday. We're here, and looking forward to another nice chat with you, and hopefully some viewers to come on and talk to us as well today.
Yeah, they're popping on, and I see some people popping on TikTok as well, to the best I can see. Hey, guys, we are on. I'll keep announcing this. We're on. What is my channel called? Dr.B Addiction Recovery on YouTube. We are on live. Me and Parham Namatola, addiction psychologist, actually one of the best I know in town, and we are going to discuss heroin detox. And I want to, for those of you that saw, there was a question posted to me on TikTok recently uh, about home detox from heroin, and I was very clear on that. I said, look, hey, if you can't go to a doctor, which I don't advise, and if you have nothing, you're going to use over-the-counter medication. This is what I suggest, and I always get the odd questions and really derogatory comments, and I kind of look at it and laugh. I'll get things like people say, "This guy has no idea what he's talking about. He should go through it." And it's like, dude, the question was, "What do you recommend for home?" And people still don't get one of the things I'm trying to do on here and on YouTube. Hi, guys, coming on YouTube is I am trying to get folks to understand, Parham, that from a clinical perspective and clinical science, individual experiences in a way don't matter. We're not talking about my experience or your experience, and we have a difficult time getting outside of ourselves. So what I felt, everyone felt, and that's not what you do. You collect a large number of people, put it into a formal, calculated, tabular sort of picture. Now you can advise, and now you can predict. That's the beauty of it. So get on YouTube, Dr. B Addiction Recovery. Ask your questions. Join us, whatever. Parham, tell me what's going on. Are you finishing basketball season next week?
No, we're just halfway through it. We're halfway through the season, doing okay, healthy, happy, all that kind of stuff. But my schedule moving forward, just for all the viewers to know that starting the new year, myself and Dr. B, we're both committed to 11:30 a.m. Pacific Standard Time every Monday, and we're going to go all the way till 1 p.m. So an hour and a half. The reason why we wanted to go with that time frame is it allows not only for us to be able to share some of our insight and provide some information and education, but also more importantly, create a platform for people to start coming on and asking their questions live and speaking to the doctor and myself. So I'm committed to. I cleared out my whole schedule for it, Dr. B.
Yeah,
For
so
the
have I.
2022.
And I want to reemphasize that, Parham. Thanks for bringing it up, guys, especially for the guys not on here. Hey, YouTube, you guys are filling this up. Two things. One, the TikTok folks on Mondays, come on over. It's free advice from two licensed professionals. Uh, it's difficult. People actually, neither myself or Parham, it takes a bit to get an appointment with me personally, and some of you that have tried can attest to that. So here we are, and it's free of charge. And we don't mind if you go off topic. We'd like to stay on topic because we enjoy the topics, and we think there's quite a bit to pass out. And so come on over. Those of you on YouTube, I love the discussions you generate, and this goes for TikTok and YouTube. But pop on here, speak your mind. You don't have to agree with us. Teach us about your experiences. We are really laid back, open, and we're comfortable in what we know. Otherwise, we wouldn't be out here speaking it, and we take our ethics quite seriously. We're not giving medical advice. We are doing the best we can, skating around that, giving general, hopefully meaningful, good advice for everybody. Let's get started, Parham. Heroin detox, and I guess we can call it opiate detox. I don't know.
Yeah, I think so, man. I mean, I prefer for you to start just to get into the physiology and what happens to when the drug is introduced to the system and leaving the system, and why people feel the certain withdrawals they feel. And I'll gladly talk about the psychosocial stuff that happens with the underlying causes of the use of opiates, the use of heroin, and what happens when someone gets clean and sober with a lot of the emotions that start to flood and the physiological pain that they might experience, mental, emotional, physical, and how the recovery process can benefit that. So I'm going to sit back, let you do your thing, Doc, and I'll gladly come in when you're done.
Yeah, I'm going to do a little bit of both. I won't get into too much physiology, but I'm going to get into I'm going to cross multiple worlds, and then you can add to it and correct me where I may be wrong in your area. One of the things I do want to say about, uh, we'll just say heroin, okay? And if someone has a particular question about pills, fentanyl, carfentanil, whatever, let us know, but I'm going to use heroin for the sake of today, for the sake of making it easy. One of the things is I feel, Parham, even to this day, uh, there's a misconception and a misunderstanding. Let me put you on this side so I can look at you and look at the camera, trying to be better at this. I think there's quite a bit of misunderstanding about what this really is, and what it means in terms of health consequences, and what is needed and when, and what the term detox implies. So what this is, what is needed, the health consequences. Number one, in general, when we're talking about the class of medication of opiates, as miserable and painful as it is, it doesn't kill you. Okay. I mean, you can literally throw somebody in a jail cell and let them sit there, and you might poop and pee all over yourself and feel like, it's the second coming, but you're not going to die from it. This is not the case with sedative hypnotics like alcohol, benzodiazepines, barbiturates. That's number one. Number two, uh, I don't point this out often because very few people know it. So if you use it, they'll think you're the idiot. But the term detox, for years, I've been advocating not to use that term. And the reason why is semantically within our cultural and social milieu, when you say detox, it implies a beginning and a major end. Some of those shows show people going to detox, and really, it's one. Imagine if you have a certain type of cancer, and the treatment of the, oh, this is a great analogy, I think. Imagine if you have a certain type of cancer, and the treatment of that cancer is multi-step. For you to beat that cancer, you have to first have a surgical resection of the lymphatics around where that cancer started to grow. Once you do that and you clear margins, you move on to a session, a regimen of chemotherapy. Let's say once you do that, you have to move on to localized radiation for a variety of reasons. That is the treatment of cancer. And somebody was out there saying, "Oh, yeah, I'm having surgery for my cancer tomorrow. Thank God, beginning and end." And I've noticed traditionally, the idea of detox as if it's all done and over with and you get to go home. No, it's a huge part of it, like opening someone's gut and removing lymphatics is for, let's say, colon cancer or something. You need to do that, and it's invasive and it's taxing on the body. But detox is better named. I think now they call it, uh, um, what is it? Assisted medication, not medication, but there's a term they actually use now. For years, I would call it medically assisted part of recovery is what I would call it, and they essentially named it something like that. If you look at SAMHSA and all those WHO, that's what it's called. So that way, there's no confusion that once you go through that initial part, you got a ways to go, which really starts to cross from using different types of medication to facilitate whatever the needs are for that individual patient, whether the needs preceded, let's say, you know, you need a mood stabilizer, sleep issue, or are a consequence of long-term heroin addiction. And again, for simplicity's sake, we're going to use heroin. We're going to assume no other drugs. So that's number two. Number three, I believe the way people have come to look at these things is categorical. And a lot of that is a consequences of me and your industry, right? Detox, residential, partial hospitalization, intensive outpatient. Uh, and I have realized that these are rigid markers, and obviously the people administrating the treatment for the most part, these folks aren't necessarily clinical, and I find clinical folks still, we adhere to the rigid menu that's given to us by the insurance industry, and it trickles down to the counselors and other treatment providers, and that's not what should be done. And so I have found that in that initial stage where there's quite a bit of support needed when someone's coming off heroin, I've done dozens and dozens and dozens and dozens successfully out of the office, right? Guys come in, and a lot of these guys don't have insurance, and we figure it out. Now, it's even hard to do it in the office nowadays because the insurances don't really pay for it and people don't want to stick around. But we figured out a way how to do it at home, keep in touch with them. So, uh, uh, I guess what I'm trying to say, and we can talk about some of the physiology of it, which some of it is actually quite mysterious. The central nervous system is basically saying, I need this. It has a huge autonomic response. Then you get the sweating, anxiety, rapid heart rate, opiates coming off of your opiate receptors in your GI tract completely dysregulate what's called peristalsis, and people start pooping, diarrhea, cramps, all that stuff. But I have found, especially with the introduction of medication-assisted treatment, which I strictly mean in this case Suboxone type of medication, buprenorphine. It's just it's a whole different thing, and so that's sort of what I want to lay out in it. And I find that you can't send patients to do it by themselves, but you have to give really strong support and guidance during that time. And it can be done. And we slice the pie any way we need to out of our practices for these folks. We have it's really a medical office. We have a support person 24 hours a day for them. We try to be accessible in the office the whole time for them, even a place for them to sleep or come in there for guidance. And it goes, usually I just simply use medication assisted treatment, Suboxone type of products. And then I do an induction and I titrate the dose and move from there. So that's what I have to say about it, except to add, I think the most important thing is moving away from that initial stage. Now that you are off of the drug, opiates, now you got to face reality. And that's really critical, where they need support in the next many upcoming months, sometimes years, depending on how long they have been using, what age they started to use at, what kind of education and social tools do they have, and what kind of support system they have. So if you are a homeless combat veteran with PTSD or CPTSD, you're going to have a more difficult time at recovery and staying sober in the long run, right? Because those social and institutional challenges are going to make relapse more likely. These folks have to learn and restructure their synaptic system to be able to cope with the stressors of everyday life, things they've been running around, away from for years. I don't find the detox so exciting anymore. I find what happens afterwards and being able to provide support for these patients and a lot of what you do a lot more exciting. So let you take over with that.
Yeah, man. Thank you, Dr. B, as always, for laying the foundation for the conversation. The second part that you talked about with talking about the definition of detox and something ending and something starting, I do want people to know that just getting off of, in this case, we're talking about heroin or opiates. That is, it's an important piece of the puzzle. It's a prerequisite for what happens afterwards to be able to safely detox off of the illicit drug that we may or may not know what's inside of it, and the various routes of administration that could be causing more harm than good, and a lot of dangers to the self and others, to get onto some more compassionate form of medication-assisted treatment or a different pathway of recovery, whatever that is. The detox part is very important, but just like Dr. B said, that's where the work begins. So when someone's coming off of heroin, heroin's an opiate, we all know that, and it's a painkiller, right? Heroin is a painkiller. So when an individual says that my drug of choice is heroin, I, as a clinician, realize that this individual at some point in their life needed, valued, liked what the payoff was from the use of heroin. It did something for that individual. It killed some type of pain that they may have been experiencing. So what kind of pain are we talking about? Well, sometimes these pains can be literal, like physical pain. I can't tell you how many athletes I've worked with in my life that they got serious injuries through the course of athletics, and they got put on Vicodins and Percocets and those kind of things. And because of other factors, that one day, they were unable to maintain the medications as the pills as prescribed because of dependence and tolerance and all that kind of stuff. And they transitioned off to heroin. And the underlying cause of all that use might have been some physical pain that happened. However, I know more people than the athletes that the reason why they started using was because of emotional pain, was because of traumas they experienced in their life. And just like Dr. B said, often at a young age. So how long a person's been using this drug is very important. So if you experience any type of emotional, physical, psychological abuse, neglect growing up, and all of a sudden you use heroin for the first time, I've heard many people say this, that heroin was like the warmest hug they always wanted, but never gotten. So they always wanted this love, this experience of love. They actually experienced the high of heroin as being like love. They wanted this love, this warm blanket wrapped around them from a person, but they never received it. And once they found it in heroin, they fell in love and they continue using it. So, and also with PTSD, you talked about some of the veterans, but there's other populations that experience significant PTSD as a result of their either employment or just lifestyle. And complex post-traumatic stress disorder, we've talked about it many times on this channel. And these individuals are using, and heroin also helps for self-medicating various mood disorders that potentially people can have, like mental illness. It helps them with at least like self-medicating their symptomology a little bit so they don't feel certain things or they don't go to certain places mentally. So when a person gets off of heroin, congratulations, that's something you need to do, because as long as you're actively using the illicit drug heroin, your ability to choose and participate in your life becomes more minimal and minimal and minimal. So when you're actually off it, you actually get to show up in your life and say, what am I going to do about the rest? What am I going to do about the psychological, emotional, physical pain that I've experienced? And how am I going to go about starting the healing journey, the recovery journey, with hopefully with a physician that says, hey, this is going to allow you to be able to get there more safely. This is going to allow you to access recovery with reducing the risk of potentially relapsing, or at least, chronic relapsing. And there's a lot of stuff there that happens. So I'll gladly, hopefully we get some people coming and talking about the various psychosomatic, social, all that kind of stuff that happens with heroin withdrawals. And I agree with you, by the way, Doc. One last thing here. You started it off saying that personal experience is valuable for the individual. However, you can't blanket a personal experience on a collective group of people and say your experience means that everyone experiences the same thing. I'm a big believer. You grab two identical plates and drop them down from the same distance, they're going to have completely different break patterns. So you can't say that my plate's going to look like your plate.
Absolutely. I'm going to get Indira on. Indira, give me 1 second. I want to add to something that Parham made me think of. Guys, we're not saying any of that initial stage is easy. We know how hard by the time that you're going to need to come off with this stuff. This is frightening, difficult, and scary. So I don't mean to minimize it, but I am saying there's a huge chunk of work ahead. And the other thing is, Parham, I always feel odd because we are asking folks, life isn't heaven and it's not apple pie. We're asking folks to face reality, which philosophically, I always have a sort of this debate in my head because things are difficult out there. The shit people have to cope with nowadays, the marginalization of large amounts of population, the discord within families, friends, work environments, social, political. So, I always, this is something we can talk about. Let me get Indira on here. She is right here. Hello.
Hi. I actually was just trying to join StreamYard. I didn't, I was just trying to listen.
But, too bad you're on now, so say something.
You know what, though? As long as I'm on, I will say, I just pulled a statistic recently from CAMH, that's the Center for Addiction and Mental Health here in Toronto. And they said over the first wave of the pandemic that their calls for mental health support via like online or by phone went up 750%.
Yeah.
So as long as I'm here, I might as well tell you that because I think that's relevant to your discussion.
Very relevant. And they actually, and Parham knows this, they skyrocketed across the board geographically. And there was a recent, I got to go back and look at this study. I was just starting to read it. Psychiatrists were talking, Parham, and they're like overwhelmed in this last couple of years. They're like, everybody's coming in. And suicides went up, teenage suicides went up, relapses went up, overdoses, as you saw our numbers here, 100,000, which they just pulled. So yeah, life is taxing. And in fact, thank you for introducing that in there, because in addition to a crappy world or difficult world that we live in, now we have a major paradigm shift of COVID, which creates things that people were already having a hard enough time. They have to shift gears and deal with new social dynamics and structures and isolations. And it's just, it's tough. So we are not telling everybody, hey, it's just this thing and I get to it. No, we get it. Tell us a little about what's up with you. Are you, you're up in Toronto? Tell us about yourself.
Yeah. And, I just came on, I clicked onto the, I was just interested in the topic and getting a little bit of an education. And I happened to just accidentally turn up on your broadcast. But I do a lot of work in public relations and in criminal law as well. And in social justice, in the social justice areas. And so I do write a lot and I do pull a lot of statistics and about opioid overdoses just going through the roof ever since the pandemic, about a lack of resources. And so I think that if you're able to share some of your knowledge about how, people can maybe come off or wean themselves off of, in this case, heroin, different drugs, that's very useful information to be giving.
Yeah. Go ahead.
Yeah.
Parham, I want to get you.
Yeah, no, I was going to say something about this statistic about 750% increase with mental health calls on, and this happens in Canada, but I'm sure it's very evenly distributed all over the world with those kind of things. And here's my philosophy of this is why. I don't believe that COVID created a problem. I believe that COVID exposed the problem.
Yep. Thank you. Yeah.
What I mean by that is so many people in Canada included, we've all become human doing. So I believe that we all have these underlying mental health, at risk for underlying mental health, but we always stay busy. We're always doing, and we're never kind of just being. So when COVID forced everybody to stop, like in our tracks and disconnect from others and just completely stop our routines, all that stuff that was inside of a lot of people started to surface up and they started to experience it at the level of the mind.
Yeah, I agree. Whatever was on the surface before is just risen to the surface now, because this is what we now have to deal with, right? Like it brings everything right up.
Yeah, Parham, thank you for bringing that up. So I have the same position, and I always put it. What COVID did was expose, to put it in a little more formal terms, although I believe it all around. It exposed our marginalized populations in a radical way. So whether that's our prisoners, whether that's our minority groups, whether it is the income inequality and mental health and substance abuse. They were already having a rough time, all of these folks. And I agree with Parham, everyone's having a rough time. But this group, what it did is it showed that they are all marginalized and we are not doing good enough as a society. Yeah. So yeah, thank you, Parham. And so are you going to subscribe to our channel now and become our buddy and come in and say hi?
Yeah, I am subscribed to your channel, actually.
Oh, good.
Yeah. Right. So that's why I was really interested in just I didn't know that I'd be participating, but I was really interested in lurking in the background and just listening to what you gentlemen had to say.
You should come on at some point, and we'll just kind of keep you on. If you can, we can discuss. Are you familiar with the Inside program up in Canada for safe? What's that?
It's safe injection harm reduction Insight.
Is that something they're doing in Vancouver? Yeah. That sounds like something they do in Vancouver. Yeah.
Well, look up some data for that, and come on by anytime and talk to us. Hello? Okay. Can you hear us, Lindera?
I think she froze.
She's blanking it out.
Just let her off so she's getting
okay. Thank you for coming on. I'll get you off, okay?
Thank you. It's okay.
We got Jonathan, but his device got kind of messed up here for a second. Hey, TikTok, again, if you're just joining us, we are on Dr.B Addiction Recovery with addiction and family counselor Parham Nematola. We are answering questions here, and we're live, and you can come on. And the topic today is coming off of heroin detox, and all related issues. And we go all over the place when it's needed. Okay, Parham. Oh, there. Oh, we got Indira, Jonathan. Okay, let's see if there's any. And things are, so much more complex nowadays, Parham, because one of the things, there was a time that the meth user was a whole different culture than the heroin user. And things are so much more complex nowadays because these things have all gotten married to each other, and there's no boundaries even within the subculture of those that abuse in an extreme way. And so there's so much to deal with each individual patient. It's tough, and Indira's right. They need all the support that they can get. But I want to add one other thing. One of the things I've noticed is obviously, let me ask you this actually. In your program right now, are you guys still dealing with a lot of the younger 18 to 26 group, 28 group, or what's your demographic, if I can ask that?
Yeah, of course. Yeah, I would say it's primary that demographic under 30 years old as the primary component. So if we're doing a bell-shaped curve, it would be the majority of the bell-shaped curve. But we have our outliers, and we have a couple gentlemen here in their 60s that are here that, primary alcohol, living local, and with no adolescents. So for the most part, I would say it's primarily that age group.
Yeah, so that's interesting, and I've been meaning to talk to you about that. One of the things I've noticed with our program, because we operate on a little bit differently, besides our homeless population that we serve through one of our venues, people that actually come into our program are older. And I have found that in some ways they're a lot easier than the very young ones. And this brings up something else. For the most part, as much as the data out there is grim, people do and can achieve sustained recovery. It is dependent on many factors, including time and age. But if we are all there for them during this kind of curve that they go through in the height of their addiction, slowing down and achieving some sort of stability, or most of the time, oftentimes real stability, they get there. And I've sort of noticed that as we've moved away from that younger, difficult group, that ours has their own difficulties, but yours is particularly difficult because families involved, very heavily involved in terms of controlling resources, and that itself creates an interesting dynamic, and could be the very reason why these guys ended up in this place in the first place. So they might not be there because of their own choice and don't see it. So any thoughts on what I'm saying?
Yeah, 100%, man. So my thing is, I'm a big believer, family involvement in the recovery of mental health and addictions. It's I can't tell people how important it is. However, I think because of the sometimes dysfunctional family roles or just unhealthy communication patterns that previously existed in families, you can't just expect for families to start talking to each other and everything goes well. It needs to be facilitated. It needs to be done by a professional. It needs to be done appropriately. So that's one thing I think we do pretty well, man, and I'm proud of. But it's a difference between the populations. So the populations that are coming here for the traditional type of aftercare model that a lot of us are familiar with, and they may or may not be living in this local area, they're only here for treatment. There's a barrier of time, distance, and travel for their families to participate. So because of that barrier, it makes it harder to actually intervene where you need to intervene and get that emotional feeling connection going on. A lot of our locals that we have that are in the local community, you know, Huntington Beach, Costa Mesa, Irvine, when they come to programming, we can also include the family in that process. And that's been a game changer. So I believe those populations, the little older ones that have roots here, that might have a home here, a family here, a career here, they actually have better treatment outcomes than the ones that are coming here and kind of being displaced.
And I've noticed that. And I was patting myself on the back, and it's not me, it's Dr. G doing quite a bit of it, family counseling. And then I was like, hey, wait a minute, demographics have changed. Got a couple of people on. We got Lucy and then Jonathan. I think that's the order. I'm sorry if I goofed it up, guys. Let's get Lucy up here. Hey, Lucy. Hi.
Good morning.
What's up, Lucy?
So I had a question. So my ex, he's just got out of prison about 2 years ago. So I didn't know the symptoms or what to tell when somebody's using heroin. So he snores heroin. So I noticed a change after he started losing weight, problems, you know. And I try helping him, but he seems like he thinks he has it under control, but I see what's going on, what's happening to him. He's working, he's doing everything he needs to be doing, but I still feel that he can't do it by himself. If he's at the point that he's buying nose jobs because he can't breathe at times when he snores. And so I think that's something you have an addiction. And every time I bring that up to him, he starts yelling, and I don't have an addiction and I could control it. But I believe if your nose is blown out like that, you lost control of it. Yeah, I mean, I don't know. Dr. B, what do you think about that?
I'm going to let Parham start off. I have a lot to say on it. We'll let Parham get going, Lucy, and then I'll add to it.
Okay.
Yeah, thank you, Lucy, for sharing that. I could tell that you're a very caring person because your ex, who's been out of prison for 2 years, you really care about his well-being and his health. Can I ask a question? Do you guys have any children together? Is that why the main reason?
No, but I have my other kids that they're not his, but.
Okay.
Yeah.
I understand. Okay, so there is some type of family component here that you want them to see him in his healthiest possible form because they look, okay, I got you. I just wanted to clear that up. So the thing about it, Lucy, is remember in the beginning of my talk, when I shared about heroin, because he said he's snorting heroin, correct? Heroin is also a painkiller, right? Yeah. So one component of it is the fact that he's physiologically dependent on it. So he's physically addicted to the payoff that he gets from heroin, which is the feeling of relaxation and calmness and that whole sensation that comes with it, even to the point that his nose is congested. So he's using Afrin, so he doesn't care about that. But there's another component. It's the emotional component that he's getting from heroin. So heroin is doing something for this gentleman that maybe he never received in his life, right? And it could be a form of love. I mean, you shared that he was a prison pop. He came out of prison, so
he complained a lot about back pain. He really had back pain, but I'm like, you can go to the doctor and get medication for it. You know, I understand prison. He was locked up for 15 years.
It's a long time, yeah.
There's other ways to go about it than going about that.
Oh, Lucy, I want you to know I'm not justifying it. I want you to know I'm not letting you know that, hey, it's okay that he's doing it for his pain. But someone that gets locked up for 15 years, that's a big time. That's an identity that you lose. It's a part of who you are that you just lose to the system. If you've had physical back pain and you've had broken bones and that kind of stuff, he's using this. It's self-medicating, literally self-medicating that pain. So for him, it's worth it to him because you know how you said if you confront him, he gets angry and upset and that kind of stuff like that? Because for him, you're saying, hey, I want to take away your medicine. I want to take away the thing that's actually helping you. And I'm not saying going about using heroin is the smartest thing in the world to do. And Dr. B obviously has different alternative methods that people can use to get off of the illicit drug heroin. And the last thing that I would hope and pray that he gets off even sooner than this conversation is because of the amount of fentanyl that exists inside of the drugs these days. So even if he knows who the plug is and where it comes from and all that kind of stuff like that, I would say that you don't know if there's fentanyl in that, and sometimes it might be the last snort. So
yeah, and he's gotten more violent. Like he don't live with me; he moved back to his parents, but he's gotten so violent. People have told me to stay away because you don't know how he doesn't want to kick that drug. You know, he's scared to kick it, but it's like you don't know what it is to kick that drug. I really don't. I mean, but
so look, Lucy. Shall I go ahead?
Yeah, the very last part I was going to say, Lucy, this part is a suggestion for you, actually. So, you know, we have these programs out there. For example, there's the community support groups. One of them is, for example, NA, which is Narcotics Anonymous. It also has a Nar-Anon, which is for family members and loved ones of people that experience addiction. Okay. And when you expose yourself to those groups, and they're free of charge and they're readily available in all communities. I don't even know where you're from, but they're going to be there. You can go to these meetings because what happens in that moment, you're going to experience a lot of different Lucy's that are there that have someone in their life that they care for that's using substances, and they just don't know what to do. They don't know how to help. They don't know where to go. They don't know how they can help their loved one. And in that room, you're going to find some solution for it. And even on the side chat here, I promise you, if you just engage with some of the people here that are very caring and loving, they'll be able to provide you with some support because in the midst of his addiction and his anger and his defensiveness and his progression of his addiction, you're the one that's going to start getting hurt here, and you're going to be the one that feels like you're on drugs yourself when you're not.
Yeah, I've even questioned myself. Is it me? You know, it's like going so far. It's like my safety that has gotten to that point. Like I feel like he's getting so high that he might just one day. You know what I mean? And it's scary.
I bet you need support, Lucy. Is what I'm trying to say.
Thank you.
Yeah.
Lucy, I'll just be brief. I'll come at it I'll try and come at a different angle to give you a perspective. Jonathan, we'll get you on real in a minute. This is a typical situation in our daily lives that we come across. Here's a guy who's come out of prison. He was probably using in prison for a long time. There's probably quite a bit of trauma in his life, whether it's 15 years being down or before that. He does have the back pain, right? And he, to a great extent, like yourself, he's also facing a situation where his social, cultural, and historical background doesn't even give him the opportunity to make the right choices. It's a mystery to him what to do, right? Yeah. As in to a great extent for yourself, and that's scary. And I don't mean that in a bad way. And this is why I do this, because all of what I do is we like to create algorithms for people. Look, this is what's going on, and these are your choices. So in his case, the truth of the matter is, if he went to the right guy tomorrow, it might take another 6 months for him to get there, right? Maybe at this moment is not ready, but engaging in care is what he needs to do. And he has to drop his whatever issues and defenses and walls that he's put up, because you cannot outsmart addiction. That's one thing. And he's wrong, because I can tell you right now, depending on where he's at, using medication-assisted treatment, this will address both his back pain and his addiction, and get it. So he has to do that too. It does happen sometimes where they get to a place and stop on their own, but you don't want to statistically depend on that. You also need to realize and understand your own limitations and what this is causing, the havoc this can cause in your life. Okay. I want you to understand that there's only so much you can do. A. B. It's not your fault. C. And it's taken me a long time to realize this. It's also not your responsibility. You have a responsibility to yourself. You have a responsibility to your children. Okay. You are not a bad person, because, somebody used to say to me when I was much younger, if you're going to help somebody, unless if you have the tools and resources, be careful how far down they are in the quicksand, because when you reach, they're going to pull you right down with them.
Yeah, it's true. I believe that. I lost a loved one to drugs, the father of my son, and I feel like I could have done a lot more for him, and that's where I'm kind of like, I see the same picture going here, and
Yeah, I see it, and that's why I said, hey, do not feel the guilt. Let me ask you, what state do you live in?
California.
Where?
In LA, in East LA.
You do, huh?
Yeah.
You should give me a call, my practice, and because and you should reach out to some of the support on the side here.
I reached out to Nicole.
Oh, good. Yeah, because I'm kind of interested in this case if he's in a mindset to get this right. But I'm also quite worried about you.
Yeah, I'll talk to you, but me myself, I have my issues. I'm not gonna stay here, but I'm trying, and it's like there can't be two wrongs in a relationship, and I need to get right. But
we're here for you, okay?
All right, thank you very much.
Yeah, come on anytime. Parham's amazing.
I will.
And we are here from you, and it's nice that you're our neighbor. We can, we'll do what we can for you, my dear.
All right, thank you very much.
Thank you, Lucy.
Good luck.
All right, thank you.
Okay.
She's so kind.
She's so sweet, right? Yeah. Let me get up Jonathan. Well, how am I? Oh, there's Jonathan.
How you guys doing?
Good. I almost pushed remove, Jonathan. Why is that saying? I looked up. Cool. How are you?
I'm great. I'm actually on here because a couple people in the comments wanted to hear about Sublocade.
Sure. They want to know about Sublocade, or what?
Yeah, somebody asked me to just explain a little bit more. I've been a heroin addict since 2003. Right now, and 2 years ago was the first time I tried to get sober, and I got on the Sublocade shot. And I ended up just taking 2 of the shots and not getting any more, and I had no withdrawal symptoms from the Sublocade, and I ended up staying sober for 11 months. And
let me ask you this. Why did you stop after 2 of the shots? And I'll get to the fact that you didn't have withdrawals, but why did you stop after 2? Because you stayed sober for 11 months. Because when you said I did only 2, then my radar went off. I'm like, shit, relapse can happen. Why didn't you stay on it for a while and go from the 300 to the 100 milligram?
Well, then it was 3 months because it was 3 months. I got the 300, the 300, and then a 100, and didn't go back. Because I had left the treatment facility I was in, and I was working 60 hours a week, and I consumed myself with work instead of keeping up with my program, and so that was what ended up leading to my relapse, was not staying in my program.
Parham, can I say something first?
No, of course, yeah. Feel free.
So thank you for coming on, Jonathan, because it's very educational you came on. Yes, it is true. I hear a lot of people that when we get off the Sublocade, there's minimal withdrawals, but at this point, it's still anecdotal, meaning that we don't have formal data, and I see it often. What I'm really interested in is some of the, this is great, and it's what Parham was pointing to, what addiction is beyond the initial stages of coming off and the long-term issue. Now, I'm a medication guy, and the minute you said I came off, I'm like, crap. We have to, and I'm sure you've learned and you could teach us about it, we have to take care of the initial thing before we can live life. I just had a kid who's a really great kid, lives down in Mission Viejo, and he's working like 40, 50 hours a week, doing this, and that. And one of the things that he did was, just because he couldn't make the appointment, he changed the doses of his Suboxone and went from like, I don't know, 24 milligrams to 8 milligrams. And it sort of went over my radar because a lot of these kids I'm not seeing, and I had made the initial contact, but he was starting to have explosive behavior, real mood things. And you brought it up again. You gotta address that issue. It's like food and water, man. And you know that. And Parham, please give us some thoughts from your end.
Yeah, the part that stood out to me, Jonathan, first of all, I read on the side chat too, you're currently sober too, in a good amount of time, right? Like 100 days or something like that?
108 days, yeah.
Yeah, congratulations, man.
108 days. Yeah.
Yeah, congratulations on that, especially after a chunk of sobriety to get back. A lot of people don't do what you're able to do, man. It's a blessing anytime you can get recovery back again. So the part that stood out to me, not really about the medication, was you said that you started working a lot, right? Yeah. 60 hours. And you started to were you working in treatment at the time?
I wasn't no, I wasn't working in treatment. I was working for an auto manufacturer.
Okay, so you're just working in any type of job. So 60 hours. And by the way, work can become a form of a drug too, because it has us avoiding ourselves. Yeah. Especially if you're working with your hands and you're focused on something. It's kind of like you're mindless the whole time, just doing something you're probably good at. And then when you go home and your hands are idle, and all of a sudden, whatever you were running from, figuratively and mentally, physically, it all of a sudden hits you in the back of the head. And as you start to move your program of recovery down and you start to move other things above it, eventually the program of recovery gets smashed. And I'm assuming their accountability wasn't too high in your life. There are people in your corner that you could reach out to and let them know what you were feeling and all that stuff. So, Jonathan, the beauty about your relapse is, first of all, you're alive and you're here. That's like the most important part. I'm sure you have people in your world, in your circle, that are passing away from this. So you're alive. Now, the second part of this becomes really important is now you have real personal evidence of what happened to you prior to your relapse. Because another thing, by the way, using heroin from the time of the early 2000s, a heroin addict that's got 108 days sober, that's cool. That's really, really cool.
Yeah, thanks.
It's a story that doesn't happen that often. So the fact that you have this relapse history now of this time that you just relapsed after 11 months, make sure you honor and cherish and value that experience and learn from it. Because if you don't learn from it, it's going to repeat itself.
Yeah, definitely.
It will repeat itself. But if you extrapolate the wisdom, the knowledge, the experience, and say, you know what, moving forward, I'm going to make this 108 days into 11 months. Then I'm going to make that 11 months into, a couple of years. And it was all as a result of your relapse. And that relapse was worth it, man.
Yeah, a guy I respect in the recovery community always says a banana doesn't get peeled until it leaves the bunch. Yeah. So I'm keeping with my support group and going to meetings and keeping on my program, my mental health, and I'm not going to let that slip by.
Good for you, man. Come back here. Come back. We're here starting the beginning of the year every single Monday at 11:30 Pacific Standard Time until 1 o'clock. You're always welcome here, man. We're going to be here every week.
Thank you.
Jonathan, do that. Come on, say hi. Consider us peripheral satellite support for you. We do honor your thing, and I wish the world would celebrate things like this. And I want to really emphasize what Parham pointed out to, where he said, learn from that. And I can't stress that enough. And that goes for everybody. Learn from you built actually your brain changed during that recovery period quite a bit. Nobody can take that away from you. That's another thing I don't like. When someone relapses, you don't necessarily need to go into detox. Nobody can take that away from you. Now you have those tools to do exactly what Parham said. And it's just being, you know, I'm not being 12-step-ish when I say stay vigilant for the rest of your life, because the nervous system is interesting. Small trigger can open up a pathway. And thank you very much for joining us, and come back. Yes.
Thank you, guys.
You got it.
Okay, we got Anthony Maud. Hi, Anthony.
I think he's almost on. He's coming here to share about his experiences with this subject. So good.
With his what?
With the subject that we're talking about, opiates. I think heroin withdrawal or addiction is what we're talking about
Yes,
here.
please do. Brittany looks familiar. Brittany, do you come see us every week?
I think so. She's pretty active here.
Yeah, she's pretty cool. She always puts stuff up.
Yeah, I do like this. We should probably start making our announcements. I know next week is the last day that I have a conflict, but starting January, I think we should just make announcements every single Monday, 11:30 to 1 p.m. Pacific Standard Time. I think the engagement we get from callers when they come in, when there's heads up, it's a lot more. I just love this, man, when people get up and start talking.
Yeah, and same with TikTok. I made a slightly early announcement, and I will do that. Hi, Nicole. And maybe Nicole, from next week, maybe we should come up with the topic at least a day before on a Sunday or something. Any of you guys can come up with the topic. Nicole, if you want to come up with something and throw it at us, Parham, obviously you can. If Austin wants to throw anybody, just throw it on the channel the way, you know how I like that thing. I think that thing's so cool.
Yeah,
Yeah.
like the premiere thingy, so that way everybody knows what we're going to do ahead of time. So we'll start doing it on Sunday. I'm going to make sure that I put an alarm to get a hold of you guys and say, what topic do we want to talk about on Sunday? So that way we can have it ready for Monday. But I wanted to come on here and kind of ask questions, Dr. B, because a lot of us in the comments are talking about Sublocade. And while we're waiting for Anthony to come on, I just want to ask you. So we had a question. If you're on 4 milligrams of Suboxone, can you transition onto Sublocade?
4 milligrams a day?
Yeah.
Excuse me. Let me ask you, why would well, no, it's meant for those from 16 to 24 milligrams. And,
okay.
You know, when someone is on a pretty, you know, as much as they might call me a drug pusher, I am very cognizant of the amount of milligrams of anything or any drug going in my patients' bodies. When they start getting down to 12, 10, 8 milligrams, I'm not going to put you on Sublocade. But on the other side of it, those on 32 milligrams or for whatever reason, those that I think are very heavy users, and it's purely clinical decision on my part. And because I know the data on it is not there, I just kind of let my clinical experience guide. I might let somebody stay on 300 milligrams every month versus 100. And in time, they'll do studies on these. Or I may have someone go down to 100 or even stay at 300 and give them an additional 10 strips for the month and follow that closely and see what's going on. But when you're on 4 milligrams, that's just too much drug. If you're, you know, if you're just kind of chilling on that lower dose, no need.
What about somebody like me who's like down to the wire, but like, oh God, man, I'm gonna be straight up with you. I just don't want to go through the stinking I don't want to go through any kind of discomfort, basically. I'm a wimp. And so I'm on such a low amount of Suboxone that to me, it almost feels like it would be beneficial to go back up and then transition to the shot. That way I don't have to worry about it. I don't have to worry about taking it every day. And I can get the shot for as long as I want and then discontinue that. And then like all these people I talk to, Dr. B, they say, I got the shot for 6 months and then I discontinued it. And it's a year later now and I'm chilling. I'm still chilling. And I'm like, I need that in my life.
Yeah, so it's a little. I'm gonna take Anthony off and let him come back on because maybe it's a goof up.
Okay.
And then I'm gonna take Anthony off here. So Anthony, I'll bring you back on shortly, just because I want to help you get on. So I can't advocate that just because my brain, as I'm open to many avenues, that one I can't advocate. Because you're on such a baby dose, to get you on the shot is such a big jump, number one. And number two, the idea of staying on this and then sliding right off, I am seeing it a lot. I don't deny the reality of it, but again, this is that the professional part of me. I would tell people that I can't advocate that because I don't know if that's going to be the same for you. I'm seeing it a lot myself. So,
Right.
So it's quite a bit of, whereas I would just stay on the tiny wimpy dose and extend it. And we can talk about this extended. And your doctor is a great doctor. I really like this guy. So that's my thoughts on it.
Okay. All right. I'll get off here and let you guys talk to somebody else. Thank you, Dr. B.
I don't know. I mean, Anthony, Nicole, sorry we haven't. I'm kind of getting back. Oh, she got off. All right. Let's see if Anthony can get on. What do I do about Anthony?
Well, I mean, if you can't connect, maybe Anthony, try connecting without the video. Just try the audio. Maybe that'll help.
Or Anthony can get off and then come back on and go from there. I think Jonathan had something cool to say, and he was saying, how do I do it to get on? I kept trying to read it. Sure, Nicole. John Fulton. The young lady that was here earlier. Oops.
No, John was writing comments. There was somebody that their loved one passed away from just kratom, and she's being shunned in the kratom community about people maybe not believing it. And she just wants that lady to get some support because
that's nonsense. It's as I've always advocated, it's a dangerous drug and it's a dangerous community at times. So she wants to call me. Can she come on here right now and talk for a minute, or?
Yeah, I don't know. I'm just reading off what's going on. Yeah.
Okay, John, will you do me a favor? Just touch base with Nicole on this. I missed the conversation. I'll be happy to do what I can. If you can touch base with Nicole. And she's very extremely helpful.
There's a good question here. Roxanne just asked, is it the same process to get off fentanyl? I do know there's a difference, but can you share real quick the difference between the half-life of, when we're talking about fentanyl or we're talking about various different types of opiates and getting off it? Because it is different.
Yeah. So let me see how I can put this. Roxanne, when you look at it clinically in terms of that initial stage of, let's use, medication-assisted treatment. Let's say I want to get somebody off of opiate and transition them onto buprenorphine product. And clinically, when you look at that, you don't make a distinction. And here's why you don't make a distinction. Because the tools that you use, and a test, a piece of paper that, let's say you take a depression test for Parham. These are all called battery of tools, right? Batteries of tests. So the tool that you use, it's not a blood screen, but it's a 30-second questionnaire, does not need or take time into account of you withdrawing. Let me see if that makes sense. So I am fully aware that these things have different half-lives. Some things stay longer, so forth. But besides that, uh, when I'm looking at where you are, so I can safely start medication-assisted treatment, time is not a calculable factor. Doesn't enter the calculus. Two, I will say this, that presence of fentanyl has really thrown things off because it's not even just the time. It has a quick half-life, but it's a different animal. For example, I have a guy who we take care of almost, we see him every day and he takes care of us now. And he's on methadone, Parham, right? He is on methadone, long time clean. I had a meth issue. We got him off that, no problem. And then somewhere along the way here, he picked up smoking fentanyl. And it's very odd. He withdraws on top of the methadone when he stops the fentanyl, even if he increases the fentanyl. And that fentanyl out there is behaving very oddly. So our team is a lot more conscientious and cautious in when they decide to initiate the first dose of an induction drug when people are coming off fentanyl, because we are seeing such odd behavior. But in general, you are not supposed to look or think, okay, 4 hours, 6 hours. Maybe in the back of your head, you're like, okay, it's 10 hours, guy's got to be hurting, right? But it's not part of your systematic approach to initiating induction. Does that make sense, Parham?
Oh, 100%. Yeah. I mean, I obviously everyone here knows that I'm not a medical doctor. That's why Dr. B's explanation of that was better. I just hear it being thrown around so often in our circles, the going into precipitated withdrawal, a little bit too quickly because they induce the Suboxone a little bit too soon when there's fentanyl present. And it really does more harm when it's too soon, I think.
And you know what I've also seen, Parham, is sometimes they're waiting a couple of days.
Yeah.
With the fentanyl, very long time, and they're still being thrown in. So if they're on fentanyl, I really try and say, dude, just come into the office and take a nap. Here, go in this room, take a nap. We want to make sure you're okay and successful at this. And this will declare itself over time. And the other thing we got to remember is the other stuff it's cut up with, right? All of this can have weird effects on the body. Okay. Next. Okay, how do I get the, okay. Here, let me do it like this. Ding, ding. Oh, there's Anthony. Anthony, you got to get on. I keep seeing you pop on, and then it keeps falling off. I know you're trying. And I know you want to get on, and I can't I'm in therapy. I actually like to supplicate. I got a ton of this content, though. I get more on here than from therapy. Try and come back on, Anthony. As soon as I see you, I'll pop you up. Because I keep looking for you, you come on and then it just falls off. I don't know if it's your computer, but we'd love to hear from you and your thoughts on everything. There's a lively discussion. Hey, TikTok, guys, come on over. And hey, those of you new to the channel, please like and subscribe us, guys.
Someone put a question there that I want to address. It says, do you guys encourage 12-step programs? It's maybe 5 comments up, really recent.
5 comments. Can you tell me that? Oh, there it is.
Yeah, I just want to touch on this one. No, not that one. The one right above it. Yeah, so what is it? It's Nyachiriboga. Man, I totally butchered that one. But I will tell you this, both myself and Dr. B, we're open to all various forms of recovery because I think it looks different for everyone. Personally, I do believe in the value of certain components of 12-step programs. The first and foremost being that there is a collective group of individuals that at least can become primary support or secondary support for people that may or may not have that in their lives. I like the fact that they're so readily available and accessible in all different communities, whether it's in person or via, telehealth or Zoom. I always shy away from anything that becomes too dogmatic in thinking and too black and white in thinking, because I don't believe that life is that dogmatic or black and white. But just like everything else, there's really, really wonderful things in those rooms. And there's also things that have not kind of adjusted with the times and the pace and the differences that society is experiencing currently. So I always encourage people to go to 12-step programs or family programs or refuge recovery or smart recovery or anything that's community-based support, because I do believe that at the core of it all, we all need it.
I second that. Parham, give me 1 second, 45 seconds. I gotta get this package here that just arrived. Sorry, guys, I'm working and doing this at the same time. 45 seconds, I'll be right there. Keep things going.
Yeah, no, so it's after 10 years of active, the only thing that has helped me stay sober is AA. And there's a lot of people there, and on the flip side of it, I know there's a lot of people that may have had bad experiences in there, and then that's okay too. I will tell you this, that I am personally 13 and a half years clean and sober from all mood and mind altering substances, alcohol, drugs, anything in between. My first 6 or 7 years was heavily invested in Alcoholics Anonymous and having commitments and working a program and learning how to navigate that world. And then I kind of got into some deeper level therapy for myself and started working with professionals to kind of address some of the stuff that is not appropriate to be shared in public in a group setting. Some of my best connections are still people that I've known through those programs. So I strongly advocate it. And if not for the individual, for the family members. I think that CODA meetings, Al-Anon meetings, Nar-Anon meetings are so valuable for the mom, the dad, the spouse, the child who doesn't know what to do about their addiction of their loved one, that the addiction of someone else is causing psychological, emotional, physical, spiritual pain in their life. And they can go to these 12-step support groups to get something for themselves, because I believe that they need it just as much, if not more, than the person using substances, because the person using substances is oftentimes comfortably numb, is oftentimes not going through the psychological, emotional, physical, spiritual pain that someone else might be going through. And we definitely do talk about it, but if someone comes in here and says they're not willing to go or they don't want to go or this and that, we don't push it on them. So hopefully that answered your question.
And same with me. Exactly, pretty much the same. I don't advocate it for anyone. I mean, I don't push it, and I have nothing against it. And I look at it like any other outside, because I just kind of focus on my clinical approach, for better or for worse. But like any other thing from the outside, whether you're telling me you're taking vitamins, or if you tell me you're seeing a psychiatrist, or you tell me you're very involved in the AA at the moment, I just kind of make sure that it's not affecting you in a negative way. There's Anthony. Let's get him in before he disappears. Anthony, I got you, man.
There he is.
Can you hear us? Can you hear us? He's on.
Well, at least we can see him now, so we have a little bit of improvement.
Yeah, we can't. Anthony, I don't know if you can hear us. And I think it's on his end.
Yeah, probably.
There you go. Anthony, can you hear us? Hey.
Yeah, I don't think so, Doc.
I don't know if you can hear us. Let me do this. Hold on. Let me put a comment up for him. We can't hear you, Anthony. I just threw it up there. Can you hear me, Parham?
I can hear you, yeah.
While Anthony's up there trying to sort this out, let me try to look at TikTok. I'm like an old man. I got like 5 different pairs of glasses. Hi. Have a blessed day. I'm addicted to Effexor. You should come on here and ask us about Effexor, Rebecca. I really would love to comment on that if you want to get on. Anthony, can you hear us? Did he say
Take him
anything?
take him off the mute and see if anything comes through. But if not, you might have to just take him off.
Yeah, I did unmute. So it says can't unmute because he chose to mute himself. Okay.
Okay.
He's having some problem. Okay. So see if you see anything on the side there. I took Effexor for 3 years. Okay. Yeah. Thank you. Oh, that's Nicole. Okay. Yeah, they have a lively chat going on here on TikTok as well, and I wish they would come on. I don't know if they're asking me if I drink alcohol, but okay. Let's see on here. No, I don't know if he was muted. I kept pushing that. My daughter is an adult. Serious. Parham, you're seeing a lot of. Are you? I know. Here's Anthony again. Let's give him a shot. Anthony, can you hear us now?
I can hear you. Can you hear me?
Oh, there we go.
Yeah. Wow, that was rough. Go ahead.
I've been on Sublocade for almost a year now, and I tried to get off of it, and I noticed that I started getting cravings. I actually relapsed, and I'm kind of begging the question is whether I should be on this medication for life, because I've done a lot of therapy, and I'm on these videos a lot and trying to learn about the best I can about my addiction. So
sure. Should I start, Parham?
Yeah, it's Sublocade. Feel free. Go for it.
Yeah, and I feel I have some strong thoughts on this, Anthony, in general. Now, I don't know your particular case, so I'm going to speak generally. Two, I'm not going to talk about it in terms of Sublocade, but because I think a better answer is buprenorphine. Because I was just telling Nicole, hey, if you're down to 2 milligrams of buprenorphine, don't go to Sublocade, or somebody was asking. And here's my thought. We, as much as I always advocate for clinical science and evidence to the best that we can, it's all statistics, we don't have formal data or a test to say, oh, it's time for you to get off of assisted medication. That's number one. Now, in our world, in our environment, it's difficult for people to swallow because they're already looking at being on medication as if some sort of failure, and I don't. So we don't have a test. So what do we have, and what does that mean? Here's what it means. It means for the clinician to educate the patient first and foremost. When you ask me, Anthony asked me, hey, doc, I'm starting this. Am I going to have to be on medication for life? And I'll tell you, Anthony, I don't know. Okay. Some people, not everybody, but not a small number, would probably benefit on staying on this medication for life. And why that's the case, you can discuss it in any framework you want. Maybe you got a low dopamine production, right? Maybe you have sleep, and whatever it is, we even know that Suboxone is a great medication for treatment-resistant depression, right? Low dose, right? But they don't say that. Okay, maybe you got chronic pain. So some people need to stay on it for life. And I always beg the question to the patient, hey, buddy, look at your life right now. You've lost everything. You're looking at hepatitis C, HIV, homelessness. This drug by itself is not the devil, right? What I'm here to do is give you your physical health back, and from there you you build on it your psychological health, cognitive engagement in this world, emotional health, and you live Who cares if you're on this medication? And I want to point that out to people. And so, hell, if you got to take this every day for life, small dose of this medication, my job is to assess the risk versus benefit, communicate that with you, and tell you the risk of quitting. Now, who do I do that with? Well, just the other day, I had a patient, and he's a great guy. He's a physical therapist. And I turned around to him and said, you know, I actually think if you're interested, we can start chopping the 8 milligrams down. I want you to understand, if I screw with your mood or craving in any way, we can always go back up. So on the clinician side, I believe it's our duty to be flexible, non-threatening, and change the course of treatment as it needed for the patient, in addition to educating so they don't feel crappy about it. And on the patient side, we should be able to get them to see it in that way. And that's my answer. I hope that answers it. Parham, if you have something to add, please go ahead.
Yeah, for sure, man. Anthony, how long before you got on the Sublocade were you using substances like opiates?
I had been I went to jail for 4.5 years, and then when I got out, I wasn't on anything, but I was very afraid that I was going to relapse, and so I got on the Suboxone and then Subutex, and then I really just wanted to get off of just taking something every day and having to worry about whether I had more cravings and wanted to take more medicine or less. So I just wanted something more concrete and something I could not have to worry about. And it's been pretty successful taking it. It's just when I stopped taking it, I began to slide back into really intense cravings that I couldn't even get out of.
And what about the 4.5? So 4.5 years you were locked up. Prior to that, did you have a drug addiction?
I was using here and there the Suboxone in small forms when it was coming into jail.
Okay.
And the K2 spice stuff. But prior to being in jail, I was very badly addicted to methamphetamines and heroin at the same time. I was speedballing a lot, and variations of crack and heroin, or pills and heroin. So I just thought this would be a really important thing for me to cut my cravings and be able to work on me a little bit better without having, something on my shoulder.
Yeah, man. I want to tell you congratulations. The logic that you're implementing into your life right now is very logical to a clinician. For someone that literally had their entire life destroyed because of drugs and alcohol, to the point that your freedom was taken away from you for 4.5 years, and coming out and saying, what can I do not to end up there again? And going down this route is a lot better option than ending up back there again. So now what you're experiencing, and from my clinical perspective, is whoever Anthony was then and there, when you were younger, the life experiences you had, the challenges, the traumas, the crap, the chaos, all of that stuff still exists inside of you. And my suggestion to you is to address all of that stuff, right? And allow the person you become after you've worked on yourself, healed on yourself, allow that version of you be the one who decides what he wants to do with medication in his life, right? Because this is allowing you to do that work. Like for someone with your background, again, not everyone's created the same, right? So someone that doesn't have a history of crack cocaine and methamphetamines and heroin at a young age, getting to prison and coming out, like your story is unique to you. So whatever you have to do to ensure that you don't rewrite your story again, whatever you have to do to ensure that, actively pursue that, continuously use that with the commitment to work on Anthony underneath all that. Because once you heal that component, man, the need for external stuff, the craving level even drops. You won't even crave drugs as much as you crave them, as much as you do right now. So allow that person who you become in the future to make better decisions for you than the current version right now.
If I may add something, Parham, he said something that's really profound and educational, and I love it because we can use it. So when he got out, it's kind of neat because I don't think he was, if I understood it correctly, he wasn't a regular user, but felt that he was in a bad, he could relapse. And he just brought out a really important point. Very few people understand that that's an okay time to start buprenorphine products. And not only did he catch it, but he found a smart enough doctor to go ahead and understand that. Because I bring that up to people all the time, and they look at me like I'm crazy. I'm like, no, dude, you're gonna relapse. Okay, you gave it a shot, so get back on. So that's really insightful of him, and I'm kind of blown away. And even now, let me ask you, since Parham started on the particulars, are you on is it 100 milligrams that you're on?
Yes.
Yeah. Now, around what day do you start to feel yucky? Like day 26 or day 35?
I'd say about 25.
Wow.
I start getting some more intense cravings.
Yeah. You know, Parham, I don't know, but over time, there might be a pretty strong physiological, pharmacological aspect to this. But Parham is right because and I'm just saying this to you. You could do everything Parham says, and I just watched the guy do that, and I asked him, "Hey, would you ever think about opiates?" He's like, "That's the last thing on my mind, right?" Because he's done so much work and engaged in life. At the same time, it seems like you are doing the work. So in a year or 2 years, if you give this another shot and it's still there, I want you to understand it's not the work. You've done the work. Some of us, again, life is a spectrum, right? This could be a very a deeply embedded pharmacological, synaptic, and physiological situation you're in, and that's okay too, right? So keep that in mind. But keep us updated, man.
Thank you. You guys have been such an inspiration for my recovery.
Thanks, Anthony. Appreciate you, man.
Take care, buddy. Good to see you.
Too.
Bye-bye. Wow, great.
That was worth it. I'm glad that we bared the technical difficulties to give him a chance to come share that, because you know how many people actually, I've seen one other case, Doc. You said that it's not common practice. I saw one other case, and this is for whoever's listening. The gentleman was locked up for 9 months, but had a 20-year history of heroin. And in the 9 months that he was in there, he didn't use any substances. But when he came out, his cravings were so high that he was terrified of relapsing to heroin. At that point, the medical director put him on Suboxone. I think it was 16 milligrams or something like that. A lot of people thought, why would you do this to somebody? And I can tell you this, that a year and a half later, that gentleman is, the dosage is a little bit lower, but he hasn't relapsed on heroin. And he says that there's absolutely no way I wouldn't have used coming out of prison.
Yeah, and I'm glad we brought this up again. You brought it up because I am very cognizant of this. And I always invite people to understand this. I'm like, oh, you want to go that road? Understand in 3, 4, 5, 6 months. And this is what pause is, right? If you look at someone. And so that was a great thing that we discussed. Let's get Sober Dog on here. Then I got to rush because I have a meeting at 1. And then I got a patient at 1:30, I think. I don't know. But I guess I'll start my meeting on the phone.
Last one.
Hey, good to see you, man.
What's going on, Dr. B? Can you guys hear me?
We can hear you perfectly.
Yeah, we can.
You guys are awesome, and just your content and information is phenomenal. I wanted to ask you about antidepressants. I saw that other comment on TikTok. I was on Effexor for a couple years and got off it, and they switched to Trintellix, and haven't had a ton of success with it. But apparently the research is very good. And then the nurse practitioner mentioned Vraylar specifically for people in recovery. Did you guys hear anything about that or see any good results?
Sorry. Parham, do you want to go first?
I actually don't have familiarity with those specific medications.
Okay. I will just simply say this, the whole class in general. And you know what? Pop on here next time, and we'll talk about that last one in a little more detail. But I can say this safely. The whole class in general. By the way, why did you come off of Effexor?
Just, it made me numb. It was just too, I don't know, like no emotion. It helped depression a little bit, but almost too much. Like not feeling happiness, not just blah.
Yeah. And then do you like Trintellix?
I haven't had any side effects from it. No, it's really been good, but also not ton of benefits, I guess, so to speak, pretty like even. But I was just very wary to switch again. I just did the switch like 6 months ago, and did a serious wean down of Effexor because I was on 225.
So, in general, I'm not giving you any kind of advice. I mean, I know you quite well, but in general, my thought on the approach on this kind of thing is leave it alone. Okay. Leave it alone. They go in there and they don't know what they're saying, and the latest and greatest comes out. It's all look. In some senses, and I hope I don't get in trouble, we're a bullshit industry in many ways, right? There's a lot of nuances for deciding a medication, considering the side effects, what pathology is, what disease processes are. And you know what? First, do no harm. We seem to forget that. First, do no harm. And the best way for me not to do any harm to you is not to even talk to you. Right, so I try to give you more jokes than any advice. Right, first, and I'm not kidding about what I'm saying. You talk to me, I can cause problems. Right, and this is the first thing I was taught myself in my residency. So I would leave it alone. There's many other discussions you could have, and you could probably talk to Parham about what you should even expect from an antidepressant. There's a huge varying degree of response, and we're learning so much more about what depression is and how we miss the total mark with the classes of antidepressants that we do use. You want to feel good? Yeah, you can slam some meth and do a line of coke. You're gonna feel great, but you got to pay the price, right?
Yep.
So realign. I mean, you look like you're walking downtown Philly or something. And
I'm at the YMCA in Rochester, New York.
New York, okay. And that's a good day, man. Right? You got a smile on your face. Take a deep breath and continue to do whatever else you're doing. And that's my general advice for anyone. Parham, you want to add anything?
No, I know you got to go right now, but Sober Dogs, recovery looks like it's alive and well in you right now. I could just tell by the way you're engaged with this conversation and some of the smiles you did. Whatever path you're on, man, just continue moving forward. I could tell you this based on personal and professional experience that committed and consistent actions over time produce positive results, man. So let that time part on the bottom build and continue doing committed and consistent actions. And you'll see how your mind and mood just naturally starts to improve over time. I'm not saying depression goes away, but when you start engaging in things that feed your soul and your spirit and make you feel good, your brain chemistry will also follow.
Awesome. Thank you guys so much. And I appreciate all the info.
All the time, anytime. Parham, he's Sober Dog's really cool. I actually watch his stuff all the time. I think when it's on TikTok, and he's great, and he often puts a smile on my face. I'm usually in a grouchy mood, but yeah, man, come on anytime and chat with us. All right.
Thank you very much, and vice versa. Same to you guys.
All right.
Have a great one, guys. Merry Christmas, happy holidays.
Yeah, be safe.
Thank you.
Okay.
Get out of here, Doc.
Okay, TikTok, guys, thanks for joining us. I got to bounce, so let me say bye to you first. Thank you for joining us. And don't forget, you can always come on the channel, and you should go under anyway and subscribe and all that stuff. See you guys soon. I got some stuff coming for you. YouTube, love you guys' participation. Me and Parham really appreciate it. I'm really lucky to have Parham with me all the time. Don't forget to check out his channels. I think his main thing is on Instagram. Is that where you're big?
Yeah, I got to get more active with it. I go in and out of it like you, Doc. I need to stay committed and consistent. I need to take my own advice. Get too busy.
You should, because so many people can benefit from your input. But I love the fact that you're here with me. I couldn't do this without you.
Thanks, man.
I would get tired of my own voice. Guys, next week, same time, check out the other videos. Please like, please subscribe. If you are inclined to do so and do appreciate our overall content, we do have a really reasonable Patreon, as little as $3 a month. And we got over 20,000 subscribers. it really helps. None of this is funded by anybody but ourselves. And that would allow us to actually really expand the content we put out, the regularity of it, and so forth. So support us, because we think we are making a change out there, a paradigm shift towards substance abuse, and all folks out there that need help. Thanks, guys. I'm going to end the broadcast.